This is my family, some recent pictures that we took with the beautiful spring flowers here in Southern California. So I've been married to my wife for almost 30 years. We're 30 years next year. And we have four boys who are all men now. And we have two beautiful daughter-in-laws and share a little bit of joy with you. My second oldest son, Dallin, and his wife, Carrera, were here visiting 2 weeks ago, and she's 29 weeks pregnant when she was here visiting and ended up going into labor and having the baby. So they are moved into our house now because the baby is in the NICU here in Mission Viejo. But I'm happy to report that everything is going really well and the baby is thriving and doing great. Haven't had any problems. But I haven't been able to hold her yet, darn it. So that's yet to come. So when she's big enough and healthy enough, I guess, for someone besides mom and dad to hold her, I'll get to do that. Her name is Lonnie. So this is my practice in San Clemente, California. Practiced there for almost 20 years with the best team in the world. Really proud of them. They're like family to me. But in 2017, I ended up with some dexterity problems in my hands and found out that I had some pretty significant cervical spinal stenosis with myelopathy, damage to my spinal cord from getting compressed in the back of the cord space or the canal space from a bone spur, and had some pretty bad degeneration in other areas, and was advised that it was best to retire from clinical practice if at all possible, because the other levels were going to get blown out and I would need multiple level surgery pretty quick. So fortunately, I back in 2007 had trained with progressive orthodontic seminars and incorporated orthodontics quite heavily into my practice, both aligners and brackets. And so now have the privilege and opportunity to work with progressive orthodontics and help you guys in different parts around the world to incorporate ortho and improve your practices. And I really love it. So let's talk a little bit about some of the benefits of doing ortho as a GP. For me, one of my favorite things doing dentistry is when I can do cosmetic work and that excitement of being able to put in a brand new smile for somebody and watch them look in the mirror and how their face lights up and how they go from covering their smile to opening up and they just feel like a different person. And when they come back in, they feel different. They get different energy. And when you start doing ortho, all of a sudden you're doing this type of cosmetic treatment on kids. You take a young person, an 8, 9-year-old whose teeth are not looking good and they're getting teased at school, and all of a sudden they come back in 3 weeks later, 3 months later, the teeth have straightened up quite a bit and they just feel like a different person. And so it's really gratifying. It's really satisfying to be able to do orthodontics with your patients, and just for me, one of the best decisions I ever made. But in addition to that enjoyment for me and my staff and my patients, I really feel like doing orthodontics and gaining an orthodontic education helped me become a better practitioner in every sense. Just understanding how dynamic the mouth was. When I would put a crown in, I just didn't want the teeth to move. I just was like, if that tooth will stay where I put it, a contact won't open up and things don't shift around. I just don't want things to move. But the reality is that the oral facial complex is quite dynamic, and there are all kinds of forces being placed from the tongue and the lips and the function, and things do move and things do change. So understanding ortho helped me work with the mouth in its reality of what it really does instead of fighting against it, and just understanding the complexity of the patients and how I can best treat each one of them for what their condition presents with. It brings a lot of positive energy into the practice, both for my patients and for the staff. Young people, teenagers, there's not a lot for them to look forward to when they come to the general practice, except maybe a cleaning, a filling. And all of a sudden, when they're coming in for straightening their teeth, they're just excited, they're happy. It brings a lot of great energy into the practice. So there's a lot of emotional reward from doing orthodontics in your practice. And then, of course, it does increase your revenues. It does. For me, we went into a recession in 2008, and having orthodontics as part of my income kind of leveled out the collections every month. So there wasn't so much up and down, and just helped things to become a little bit more recession proof and gave me that additional source of income. I was referring out a lot of ortho, and I decided that probably the best thing to do if I was going to get more education in any field was to do something that I would enjoy, and that was what I referred a lot of it out. And so doing an ortho education was just key for me. And then I started getting referrals from kids, from teenagers, and adults who were doing ortho with me. But it was pretty amazing to get a new referral, a new family, and go, hey, who referred you here? And it turns out that it's like one of your 12-year-old patients that referred the family in, and that kind of stuff is pretty exciting. Let me just mute everybody here real quick. And then, being able to do cosmetic work, whenever you start talking about orthodontics and doing orthodontics, it always leads to more cosmetic and full mouth restorative work, more comprehensive dentistry, which is the kind of dentistry that I think we all really enjoy and love doing. And then being able to prepare, in a case for restorative work for veneers or crowns on the front teeth, or for an implant placement, being able to do that work myself in my practice rather than refer that out to an orthodontist and hope that I get it back, is really exciting. Plus, I could make it work for the patient. Maybe they came in because they wanted veneers on their upper front teeth and they didn't really come in for ortho, but I can look at them and say, if I could straighten your lower bottom teeth, that would give me a nice platform to build your new crowns on these upper front teeth that need restorations, and it will look great. And so I can give you a great deal on straightening your teeth first so that we can then do your restorations and have everything look great. And or being in charge of the implant placement, figuring out where I want that and getting the teeth all straight. Just having that control and being able to provide all these services for my patient and work it all into one total case fee was really just a really nice way to practice. Um, and then improving the aesthetics, the function, the longevity of the restorative work that we do. A lot of benefits of ortho to patients, right? So your patients enjoy healthy, functional, aesthetically pleasing smiles. Before I got an ortho education, I just was like, ortho is for aesthetics. I didn't really bring up orthodontics. I didn't really know what I was looking at because they don't teach us a lot in dental school. And so I really only talked about orthodontics if somebody brought it up. Hey, does my child need ortho? I'm not sure. It looks like their teeth are pretty crowded. Maybe you should refer them out. Go see a specialist. Or if an adult said, do you think you could benefit from braces? Like, I just wasn't something we talked about much in the practice. And so I didn't really see how it fit into the overall health of the patient. It was more just something that was aesthetic. And then when I learned ortho and started doing ortho, I realized what a benefit is to the patient beyond just the obvious fact that their smile is going to look nice. It's going to be aesthetically pleasing. So improved facial balances, meaning the way that their lips and their face look even before you see the teeth, improved oral health and function of their mouth, improved jaw and occlusal function, speech. Properly aligned teeth are easier for the patients to keep clean. It reduces the risk of decay and tooth wear and fractures. And if I do put restorations in the mouth, they're going to last a lot longer. They're going to wear more evenly. So they have longer, better retention of both the restorations and their teeth for a longer, healthier oral health. Um, you guys all, you would never take your car in and get new tires put on without aligning your wheels. If your wheels are out of alignment, you would align the wheels as part of replacing the tires, because your tires are going to wear out quickly and they're going to wear unevenly if we have the wheels out of alignment. And so that's one way that I would help my patients understand that I'm not looking for just aesthetics. We're looking for function. And the car drives better when the wheels are aligned, the tires don't wear out, things don't bounce around and break, because when things are in alignment, everything functions better. So it is aesthetically pleasing to have straight teeth, but it is more about function and oral health. These are some of the things that we see happen in patients' mouths when their teeth are out of alignment. The front teeth can wear unevenly, irregularly. They can get thinned out and chipped. We can see abfraction lesions. We can see teeth that are under heavy loads, heavy occlusal trauma, and certain parts of the teeth will break off. You'll have cusp fracture. You'll have the porcelain break off your restorations. These are the types of things that we see when teeth are not wearing regularly, when they're out of alignment. And then from a periodontal health standpoint, when teeth are crowded, we know that you don't put implants in the mouth unless you have enough bone around the implant, so you're not going to put it right on top of a tooth or right on top of another implant. We respect the fact that you need to have bone surrounding that implant because it's required for that to be healthy and to survive. But our teeth also do not thrive when there's not enough bone around them. And so when they're crowded and the roots are on top of each other, it causes periodontal conditions. It'll cause bone loss. It'll cause areas where you constantly have inflammation. And so aligning the teeth, it not only makes it easier for them to clean, but the bones and the gums around the teeth that support the teeth are just healthier because it has proper blood flow and proper amount of bone in between each of the roots when they're in alignment. So aesthetics, but also function and periodontal health. And it's even more than that. When you look at how people use their mouth, when you look at habits like tongue thrusting, people who can't close their lips around their teeth, they're lip incompetent, they can't breathe through their nose, and so they're mouth breathers, right? These things have they have a bad effect on the patient. Um, there's a lot of studies out that show some of the bad effects on patient health from mouth breathing and from poor function of the mouth. And then facial development, if we allow some of these things like a functional shift, if somebody has a small maxilla in the transverse dimension and they have to shift their mandible to the left or to the right in order to close their mouth together without hitting on cuss tips, then this causes them to develop asymmetrically. Their bones will grow asymmetrically. And so facial development, function, there's a lot of things involved with aligning teeth. And so understanding what's happening, when to do treatment, how to do treatment, or if you're not going to do the treatment, at least understanding when to make the referrals, why you're making the referrals, be able to talk with your orthodontist or talk with your parents. All of this was just something I really wanted in my practice and was one of the best choices that I ever made. So my question to you is, in your practice, how many ortho cases are you referring out each month? I found that I was referring out at least a couple of times a week. As a young doctor, young practice, I had a lot of families. And so I was pulling out that referral card at least a couple times a week. And that was just the ones where patients were asking or where it came up, but it wasn't me trying to actually diagnose ortho conditions. So if I'm actually talking about ortho and diagnosing orthodontic conditions on every one of my patients as part of my routine exam, then how many of my patients are going undiagnosed and remain untreated? So how much production is being lost in your practice? The reality is our practices as a general dentist is a gold mine full of opportunities. And if we get excited about doing orthodontics in our practice and get our staff on board and get them excited, maybe start treatment on one of our staff members, it creates excitement in our practice and helps us to put everything in place to be able to start doing orthodontics in our practice. And so, my hope in the couple hours that we have to be together, it's less than two now, is that you gain some excitement, or maybe you're already doing some orthodontics in your practice and you'll reignite that excitement and maybe see some ways that you could improve your efficiency and opportunities for more education that would help you be a better practitioner. So looking at the return on investment, because obviously starting ortho, you're going to have to invest in some education, you're going to have to invest in some instruments, you're going to have to invest in some supply in order to offer orthodontics in your practice. But there is a great return on your investment. And if you think about the number of referrals that you're making, plus the number of patients that could benefit from ortho, but you don't even ever talk about it or diagnose it, it's not unreasonable to consider finding one patient a week that would be willing to start orthodontic treatment. So you could start somewhere around 50 to 52 orthodontic cases per year. Okay, that's a pretty, I wouldn't say that's a real aggressive number for a general dentist. I think it's a healthy number, but I don't think it's really aggressive. There's a lot of general dentists that do a lot more than that. But at that number, at an average of $5,000 to $7,000 for an ortho case fee, you're looking at an additional $260,000 to $365,000 per year to your revenue, which can make a big difference for our practices. Not to mention the additional services that we end up providing as a result of discussing orthodontic treatment or doing orthodontic treatment. So ortho is something that takes, at least 12 to 18 months to complete on a patient, sometimes up to 24 months or longer. And so you can actually have your patients paying for your education. So you're earning from the cases you're starting and you're learning how to complete them as you're doing the treatment. And it's basically paying for your education as you go. So some of the additional revenue sources that I found from orthodontics in my practice, one is just the periodontal services. You can't start ortho until the patient has healthy periodontium. So if they have gingivitis, if they have any periodontal disease, we have to get that under control and get that cleaned up before we actually start doing the orthodontic care. If there's any endodontic lesions, even quiet ones that have been sitting there for a long time, but those all have to be cleaned up before you start moving teeth around. And then caries control. So we have to make sure there's no caries in the mouth, which then means we're going to be doing restorations afterwards. If we had to do any provisional crowns or anything that, I'm not going to replace a crown before I do the ortho. I'd like to put on a nice provisional and cement that with permanent cement and then align the teeth and then come back and put the permanent restoration on. So there are a lot of periodontal, endodontic, and restorative services that result from doing ortho. And then sometimes extractions, if we're doing extraction treatment, sometimes extractions is part of the revenue from ortho, especially on the kids where they're transitioning out of primary dentition and we want to get started on the adult teeth to do the ortho. We'll end up having fees for extracting primary dentition early. Sometimes this will lead to sleep, airway evaluation, and treatment if you do that in your practice. Placing and restoring implants, idealizing the alignment of the teeth so that you can place those implants and restore them ideally. And then just cosmetic work. Whenever people get their teeth straightened, they always want to have them whitened. And I always include the whitening because that's easy for me. I'm making them clear retainers anyway at the end, or I'm getting the clear retainers from the aligner company. And so giving them some whitening gel is an easy thing to do. So that's always included in my case fee. But whenever they get their teeth straightened and whitened, there's always an old crown, there's a couple old fillings, there's just things that don't look great anymore, and they want to make that look nice and they want to fix that. So doing the ortho does generate additional revenue besides just the fees that you collect from doing the ortho. Additionally, sometimes patients need a little bit of gingival recontouring after the ortho. So using an electrosurge or using a laser if you have that in your practice and doing a little bit of gingival recontouring, or maybe you do gingival grafting and you would do some grafting after ortho, making retainers, splints after ortho. If they weren't in night guard, they're going to need a new night guard after the ortho. And then sometimes patients don't wear their retainers, and then you end up having some revenue coming from some ortho relapse if the patients need to re-straighten their teeth. But again, the amount of aesthetic work that's initiated because of the conversations when I say, hey, have you ever thought about straightening your teeth? Even if they don't end up straightening their teeth, just that question we end up talking about aesthetic work. And it leads to a lot more work when we have these questions. So here's a quote from one of our doctors, Joanne Lee in Honolulu. She said, adding ortho was the best decision of my career. And I wholeheartedly agree. It was the best decision I ever made for my practice. And not just financially, as I said, it's emotionally just very rewarding and fulfilling. So some of the top reasons why general dentists want to learn how to do ortho is one, they just want to be able to improve the care that they provide to their patients, have a deeper understanding. Two, they're looking to boost their profits, increase their revenues. And three, to meet patient demand because, your patients really don't want to go to another office. If they like you, they're confident in you and your staff. And so if they need a service that you can provide, they want you to provide that service. And so, roughly 50% of the doctors who start learning with us mention that their patients specifically asked if they did ortho, if they could straighten their teeth for them. So learning this skill really is something that just keeps on blessing you, your staff, and your patients. And what we want to do is help you feel confidence, get the education that you need to get and feel confidence and be successful and be able to thrive in your practice and really elevate the level of your practice. And, for me, doing ortho has just been a lot of fun. In dental school, they keep it kind of a mystery, right? We don't learn a lot about. I think all I did in dental school was a little single tooth anterior crossbite, and I made a little retainer with a finger spring together with another doctor. So it wasn't even my case alone, and we pushed the one tooth out of crossbite. So really, we didn't learn anything. So it seems very mysterious, and really, it's understandable. It's easy. You guys are all just as smart as anybody who decided to go to orthodontic school, but we need to invest the time in getting a proper education. We don't just jump in and well, I did, and maybe some of you have, when before I ever started training with progressive orthodontics, I took on a few Invisalign cases and realized that I could get myself into trouble really easily because I was doing things that I really didn't know what I was doing. And I didn't know which cases were going to go well, which cases weren't going to go well. I basically just sent the thing to Invisalign and trusted that they would give me back something that was correct, which is, I don't know why I ever thought that was okay, because we're the doctors, we're the ones that have to make a diagnosis and make a treatment decision and then know how to do it. And plus, if my patient ends up not wearing the aligners or things aren't working out well, what am I going to do if I can't put braces on and fix it up? I don't want to send it off to the orthodontist halfway through treatment and say, hey, can you bail me out here? I don't like doing that when I'm extracting teeth or doing root canals. I like to be able to finish the things confidently that I start. But you guys can learn to do ortho at or above the level of the specialty. And that is our objective, is to help you gain that level of confidence. So initially, we're going to try to find cases that are appropriate for our level of education and expertise. But this is just one example of somebody where the orthodontics that was done was pretty straightforward. This was one of the first cases for this particular doctor. This was treated by Lucy Galletley out of Australia. And I think one of her first aligner cases. And, for this patient, obviously looking at the pictures, this was an aesthetic improvement, significant aesthetic improvement, but functionally, you can see that he was beating up and deteriorating the edges, the incisal edges of his upper and lower incisors because of the traumatic occlusion. And by creating proper overjet, proper overbite, the patient now has not only aesthetics, but has function. And now, yes, the teeth still continue to wear just like tires do on a car, but if they're aligned properly, then everything's going to wear evenly. So this is a really nice service to provide for a patient, and you guys can definitely learn how to do this. At Progressive Orthodontic Seminars, we have 3 different levels of education. The first one is basically kind of like what we're doing right now, only these courses were presented earlier this year. It was a 2-day course where we taught this 5-minute ortho diagnosis app, which I'm going to show you guys in a minute. We'll have more of these next year. They're kind of our intro courses that we run at the beginning of the year. But if you're interested in that, you can talk to Iveta, and you can get for $99, I think, the recorded version of that and watch it. Yes. But we do have other classes coming up this year that are just starting, which is level 2. We're going to talk about this is called Selective Orthodontics, and this is an 8-day series over 3 different weekends. And in this series, we're learning how to select and treat uncomplicated orthodontic cases. So we'll talk more about that. But level 3 is learning basically everything there is to know so that you can treat like 90% or more of the cases that come into your practice if you choose to do so. So that's our comprehensive orthodontic series. That's what I started with because we didn't have anything else. That was the education that was offered when I started back in 2008. But it was fantastic. I mean, what an amazing education, amazing instructors, amazing mentors. These doctors who taught me and mentored me really made a huge difference in my practice and my life. And we're still friends, and I'm still grateful to them. So quality orthodontic care always starts with good case selection, proper diagnosis, and an effective treatment plan. So how do we choose the right cases? How do we diagnose them properly? And how do we come up with an effective treatment plan? With modern technology, everything's moving towards digital. And so we've really focused on learning and teaching in a way that supports this digital workflow. So if I was in practice today, every new patient or returning patient that came into my practice would have a full mouth scan as part of their intake records. And so I wouldn't be pulling my scanner out, my intraoral scanner, just when I'm prepping a crown, but I would be pulling out my intraoral scanner to take records on every single new patient. One, because it gives me a lot of information to have for that patient, but also because it allows me to diagnose all of the conditions and effectively communicate that with my patient. So I want to demonstrate an app with you guys really quick, and then we'll talk a little bit more about it. But this requires a intraoral scan. Okay. And the idea is that every patient who comes in would have a scan done, as kind of just like taking x-rays. Everybody gets a scan done. And then while the staff member who took the scan is waiting for me to come in and do the exam, they would spend 2 or 3 minutes working through this app so that when I come in, I have straight teeth that I can look at next to their scan so that we can make the discussion of orthodontics part of our exam. So let me switch gears here and show you this app and how it works. And then we'll talk more about it again. So switching over here, I am now in MeditLink. Okay, this app was developed between ourselves, Progressive Orthodontics, and MeditLink. or Medit. Okay, now you don't have to have a Medit scanner in order to use this app. This is free and available to anybody because Medit Link is an open, free platform that anybody can use. The advantage to having a Medit scanner is that you scan directly into Medit Link so that this app is available to use, directly on it. But if you have another scanner, you can export your file, the STL or the .ply file. You can export that scan out of your computer and into this software and be able to use this. Okay, so here we are with a scan of the upper and lower teeth in occlusion. And so let me show you what I would have my staff member do and then what I would look at with my patient. So the first thing that we do is we place 4 dots and they go on the distal buccal cusp tips of the lower first molars and the buccal cusp tips of the lower first bicuspids. So the 6s and the 4s. And what that does is it sets an occlusal table or an occlusal plane to which all the teeth are going to be aligned in the vertical dimension. Next, the AI is going to segment the teeth. So it's going to try to identify and segment the teeth. Okay, and it doesn't always get it perfect, depending on how crowded the teeth are and how good the scan is. Sometimes it does better than other times. So my job is to go through and make sure that the teeth are all labeled properly. Now I'm using international tooth numbers here. So the upper right quadrant is 1, the upper left is 2, and then the lower left is 3, and the lower right is 4. And then the teeth are from 1 back to the 8s. So we have 1, 1, 2, 1. Okay, so I'm just looking at the numbers here to make sure that they're all numbered properly. And on the top they are, but I need to clean up some of the way that it segmented the teeth. So I click on the tooth and I erase what it had done. This tooth's only partially erupted, so you can see it, did its best to paint that. So I can go in each one of these teeth, just quickly re-identify the part of the tooth that I want it to identify. Whoops, didn't mean to do that. Here we go. And this one's only partially erupted, so I'm going to show you what I'll do with that one in just a minute. So we'll confirm that the upper arch looks good. The teeth are all numbered properly and properly painted. And the lower arch, everything looks numbered correctly, but I need to adjust the way that it painted a couple of these teeth. Okay. So the one tooth that's not really erupted far enough to really show up well in a simulation is this 2-5, this upper left second bicuspid. So I'm going to come over here and tell it that that tooth is partially erupted. And what the software is going to do is it's going to take this fully erupted 1-5 and it's just going to copy that. It's going to duplicate it and it's going to flip it over and it's going to put it over here on this side. And that way we get that tooth. Let me just clean this one up. There we go. Okay, so now we'll move on to the next screen. And that one was a little bit more complicated. Some cases there's nothing to do on that screen. But because those teeth were all crowded, it came in with a little bit of work to do. And then if we have a lateral ceph, which when you come to our education, we'll talk a lot about why a lateral ceph is important, part of our orthodontic records. But if we have a lateral ceph and we've uploaded it, it's going to auto trace that ceph for us. And I can go in and make a couple of little adjustments here, but it actually is doing a pretty good job of auto tracing the ceph. Okay, so not a lot of work for me to do here. And we teach you when you come in all about what you're looking for to make sure that that's correct. Okay, but I'm going to here attempted to take this 2-dimensional scan or the 3-dimensional scan and place it onto a 2-dimensional image in the proper orientation and in the proper size. And you can see here, it doesn't really have the front teeth in the right spot. So what I'm going to do here is detach that and I'm going to identify a point in the front on the model and in the back on the model that I can easily find on the ceph so that it can reorient. Now you can see that the teeth are in the right spot. Okay. And then it tells me that this patient has a width measurement, which is measuring the anterior posterior relationship of the jaws. We'll talk about this in a minute. It's giving me a green light on that one, saying that this patient has normal balance of that anterior posterior sagittal relationship of the jaws. And in the vertical dimension, it's giving me 30.2. That's a yellow. So I'm going to look and go at 30, look at it was green up until 30. So at 30.2, I'm just barely outside of green. So it's essentially green, just barely turned yellow. Okay. And these are little traffic lights to help me understand the complexity of a case without spending a lot of time looking at it or having a lot of education to understand it, depending on what level of care you want to provide in your practice. Okay, then here what I'm doing is just picking from a list of different arch forms that we have to choose from. I'm picking one. Usually the default one is medium ovoid. It's usually a pretty good fit. And I'm just making sure that it looks symmetrical on the arch. Okay, because it's going to align the teeth to this arch form. So that looks good. And then it's going to attempt to auto-classify the teeth by identifying the mesial buccal cusp tip of the upper first molar and the buccal groove of the lower first molar. Okay, this case is not, there is a little bit of class 2 in this case, but it's close enough to class 1 that it's just going to run class 1 simulations. Okay, you have to be over 1 millimeter in value here before it starts running class 2 or class 3 simulations. So we're going to go with that. And now this is where it takes about 30 seconds to a minute, depending on the speed of your computer. It always goes a little slower when we're on Zoom because Zoom is using my CPU as well. But this is where it takes about 30 seconds to a minute. And that's why I would teach my staff member how to do the previous steps, just how to routinely do that on every patient. So that when I come into the operatory to do an exam, I would like to have this view sitting on the screen. Okay. And yes, this is a younger patient, but if this was an adult patient, they would have fillings, they would have decay possibly, they would have restorations, they would have all kinds of things for us to look at on the scan. And if you have a nice color scanner, this particular scan was taken off of I think, Medit i700. This was from Dr. Weber Chen in he's in Australia. Um, there's a lot that you can look at with the patient. So I used to use a mirror to look in the patient's mouth and try to help them see what I'm seeing. But if I do my exam and then set the patient up, it's really convenient to look at the teeth and discuss with them. And you can even see here, like, oh, hey, looks like we did a sealant on this tooth and maybe it's peeled out a little bit. Maybe we should go in and fix that sealant up. Okay, but anything that you see that needs to be discussed, it's very easy to discuss it here in this view because they can see what you see. And while you have straight teeth sitting right here next to it, it's pretty difficult to not discuss straightening the teeth as part of treatment. Okay, so of course we're going to start to talk about alignment of teeth. And yes, in a younger growing patient, this seems obvious, but in an adult patient who maybe didn't think about the alignment of their teeth, this is pretty eye-opening for them to be able to see what it would look like for them to have their teeth straight. And it was so easy to produce this. It just takes about 3-4 minutes chairside to produce it. And then I can have a conversation with the patient and we can look at their mouth and we can talk about straightening teeth and how it might benefit them, what it might look like, what kinds of treatment we might need to do. This is a pretty simple, straightforward case for this patient. Okay. And so if I have a Seth, I can actually look at this patient and I can say, if I pull up this patient's pictures, which we probably should have done before we started the case, but if we pull up this patient's pictures and go, if we want to treat this patient and we look at her profile, do we want to see her lips go forward? Or do we want to see them stay about where they are? Or do we want to see them come back? And, I would say that she looks pretty good. Her upper lip is a little bit further back than her lower lip, but it doesn't really look like I want to push her lips further forward. She would be pretty protrusive if I had her lips go forward very far. But she's young and I like the fullness of the lips. I really wouldn't want to retract them. So I'm looking to kind of keep her teeth about where they started. Okay, so here's the photos looking at the gum tissue down there. It's a little bit thin on those canines. And I would say moderate to maybe slightly thin on the lower incisors. So I'm definitely both for her face and for the health of the gum tissue and the bones that are supporting her teeth. I'm definitely not going to want to push those teeth very far forward to get them straight. But the crowding that this patient has is definitely causing the teeth to have to move forward. So if I look at this overlay, just straightening her teeth, you can see that the lowers are going to have to go forward quite a bit. Okay, and that may be a little bit too much strain both on her tissue, and it may be a little bit too much of fullness for her facial profile. So I can look at other options and I can compare, say, for example, an expanded arch form. So if I was going to do braces or aligners, because you could use either successfully on this patient. If I do expansion, let's see what that looks like. Okay, so here I have an expanded plan sitting next to a non-expanded plan. So if we look at the ortho being done, you can see on the left that there's definitely expansion going on. So if I was doing braces, I would use an expanded arch wire. And if I was doing aligners, we would use the aligners to push on the lingual surface of the teeth and expand those teeth out. Okay, so if I look at the expanded plan and see, well, how much advancement is this? And look in here, you go, oh, those incisors are finishing about where they're starting. So that's not going to put too much pressure on that gingival tissue. And looking at her ceph, that's finishing with those lower incisors right about where they started. And so that's the kind of plan that I'd be looking for here, something like that. You know, maybe we would consider extraction. So let's just see what that looks like. So if I went to one of the plans that's available here to look at and looked at the extraction plan, I could see that that would probably be too much retraction of her incisors and probably not good for her profile. It's probably too much retraction. So I like this expanded plan. Maybe I could go, well, what about expansion and IPR? Because I could certainly add some IPR, some interproximal reduction, make the teeth a little bit smaller in the front. So if I end up still feeling like her teeth are too far forward after let's see, that's actually just IPR. If I do IPR and expansion, it should be a little bit more retracted than this one. There you go. So that would be IPR and expansion. So here quickly, I'm able to look at and just get an idea of, hey, is this an appropriate patient for me to treat? I got green flags at different stages along the way, right? So when we were here, I got a green flag for the vertical and the horizontal relationship of the patient. The vertical was just barely slightly yellow, but it's still almost green. Okay. And then when I was at the bite classification, the bite was green. And so this should be a pretty easy case for us to treat, aligners or brackets. And I'm able to find a simulation that's showing me that I can treat just by expanding. I don't have to extract teeth. I can treat her to where it's going to benefit her face and her tissues. Okay. And give her a nice full smile. So I would like an expanded plan on this patient. So I can select that. And then it gives me a choice of whether I want to do aligners or brackets. Now, if I'm going to do aligners, there's ways to do aligners. We have progressive aligners, which I'll talk about in a few minutes. You can send the case to Progressive Aligners. You can send the case to any aligner company. Or some people make their own aligners. That's becoming more and more of a thing. So for doctors who are making their own aligners, this will actually stage an aligner treatment plan. And there's different ways that you can use the staging. This is very slow staging, so you could actually speed it up and have fewer aligner stages, but it will actually stage the aligners out for you. And if I like that, I can print a treatment plan to help me accomplish that aligner treatment plan. If I wanted to do brackets, because we do teach you how to do brackets in our courses, it's a really important skill to have. Then it gives me all of the brackets that I need to order from the Progressive Dental Supply and the correct wire, because remember I chose an expanded plan, so it'll give me the expanded arch wire, and it will give me the appliance that I need to order to treat this case, and it will give me a bracket treatment plan, so step-by-step instructions on how to treat this case. Okay, so coming to the education, you're going to learn what all this means, how to do this in your practice, how to actually pick the right plan and carry out the instructions in here. Okay, but the process is pretty simple. And with technology, we're able to produce something that, pretty quickly is something that we could do in our practice. I'm looking down here at these lower brackets and I see that one of these incisors has an LA bracket instead of an LI bracket on it. For those of you who know what I'm talking about, if we go back over here to the tooth orientation, because what I didn't point out to you guys, it doesn't always align everything perfectly. And if you look at this lower incisor right here, that one doesn't have the root in the same angulation as the other teeth. And so something like that, I go into tooth orientation and I change the way that it interpreted the orientation of that tooth. And we go back and look at the simulation, you're going to see that that now has better alignment. Now you can see that root is in better alignment. So little adjustments that we want to make are pretty easy to make. But if I go back now and look at the brackets on that one, I bet you we'll have a different bracket. See, now that bracket matches the rest of the brackets because it goes, oh, if you want the root there, then you should use this bracket. If you want the root where you had it previously, then you should use that other bracket. Okay, so there's a lot that we can do with this software. We've just scratched the surface. I just wanted you guys to get a feel, a taste for like what technology, what tool are we using to be able to quickly and efficiently talk to our patients about ortho and make an ortho diagnosis in our practice. Okay, so let me switch back over to the PowerPoint presentation. And let's talk a little bit more about this. So this is an overview of this digital workflow. It's taking a scan of our patients. It's spending a couple minutes in this progressive orthodontic simulation app. If the patient's interested in straightening their teeth, we can send it to Progressive Aligners. We can send it to another aligner company. We could make our own aligners. We could send it to our other software platform, which is called SmileStream, where we can order brackets and wires and treat the case with brackets and wires. And then while we're in treatment, we monitor the patient remotely so that we can cut down on the number of office visits by using another awesome technology that was developed by a company called Dental Monitoring that we've partnered with. So dental monitoring is basically just using the power of the phone that this supercomputer that each patient carries around with them, and what we call a scan box, which is just basically a holder for the phone that places the camera of the phone in the right position in a little retractor that goes in the patient's mouth. And then there's an app, and the patient stands in front of a mirror and follows the instructions on the app to move the scan box in a way that captures all of the information needed for AI to evaluate what it's seeing and tell the patient whether, if they're wearing aligners, whether they can go to their next aligner. You know, because everybody asks, like, when should you change the next aligner? And the reality is, having a set schedule is really not the ideal time to change the next aligner, because it's like, when do you take the cookies out of the oven? You take them out when they're done, right? And everything, depending on your elevation and your oven and everything, everybody has a slightly different time. And so when is the best time to take it out is when they're done and when it's cooked perfectly. And so with aligners, it's the same way. It's ideal time to change the next aligner is not 7 days or 10 days or 14 days and have a set schedule. The best time to change the next aligner is when the one you're wearing is done, when it has moved all the teeth into the right position to where that aligner it's done. It's accomplished its goal. That's when we change the next aligner. So with this monitoring, we have the patients with aligners, they scan every 7 days, and the AI either tells them that their teeth are fitting perfectly in the aligner and they can go on to their next aligner, or it says that it's not done yet and they need to stay in that aligner longer. Maybe they weren't being very compliant that week, but it tells me to stay in that aligner longer, and they need to use some little chewies and bite up and down to get their teeth to move into that aligner before they change to the next one. So this is a dynamic aligner change schedule. Okay, but having the patients involved, you know, when we do braces, we're the ones straightening their teeth. My assistant or whoever's tying in those arch wires is the one applying the forces to the teeth. And as long as the patient doesn't go rip their braces out with some pliers in the garage, they're going to get those forces applied to their teeth and their teeth are going to get straight. But with aligners, they have to straighten their own teeth. They have to apply those forces. And so that's one of the weaknesses of aligner treatment, is that the patient might not wear their aligners. Well, when they're responsible for their own aligner changes and they're, you know, accountable to this AI software, they're more engaged and they know that they can't move on to the next aligner until they finish the one that they're in. And so it really does engage the patient and improve the treatment results, but it also results in a way fewer office visits. And, you know, people don't even want anymore to go out and get their food from Taco Bell or whatever. You know, everybody's door dashing and Uber eating. And so, the modern world we live in, yes, they love you. They do love coming to your practice, but the honest truth is people don't want to take time off work and they don't want to take their kids out of school to come in for visits where there was nothing to do except say, it all looks good and here's some more aligners. Or it all looks good. Let me just change your little elastics on your teeth to a new color. So for the patient, it's very convenient for them to be able to be treated remotely until there's something that needs to be done in your practice. And for you, every time a patient comes in, it costs you money. Anywhere from, if you do the math, $150 to $250, because of the time you're paying your staff to schedule appointments and set up rooms and be with the patient and clean up the room, and then your time lost doing other production. So it does cost money every time a patient comes into your practice. So if we're looking at making orthodontics not only a fun part of our practice, but also a profitable part of our practice, this new technology, dental monitoring, is really a game changer. And it makes you able to take on a lot more orthodontic cases and still do all your other dental treatment, but actually be able to take on and monitor and treat a lot more orthodontic cases so that you can be productive and effective. So let's talk a little bit about this education called Selective Orthodontics. Okay, this is Lucy Galletli, who I mentioned earlier. This is one of her patients. She was treating this patient again early on in her education, taking selective ortho from us or a similar course and learning how to do aligners basically. And she said, by taking the selective orthodontic course, I was able to better serve my community and keep up with the changing times of ortho. And, did a really beautiful job on some cases and found that she really loved it. And now she's taking the full comprehensive 48-day course and learning how to do brackets and extraction plans and all everything, mixed dentition, all the stuff that you can do with the comprehensive ortho course. Okay. So this selective orthodontic course, this 8-day course, it's taught over 3 different weekends. So it's 2 days the first weekend, and then it's 3 days the next weekend. And then the next weekend is 3 days, but one of those days is an optional hands-on lab, which if you already have experience putting brackets onto teeth and doing aligner treatment, then maybe that hands-on lab isn't necessary for you. But everybody who's new, we want you to not only learn the things that we're going to teach you from the slides and the conversation and the pictures, but we also want you to actually do it, because there's a skill set that you get from actually placing brackets on a model and learning how that feels, how to put coils and tie in the wire, how to do the actual hands-on things that you need to be able to do in your practice. And so we want you to have that hands-on experience so you can actually go do that in your practice. The purpose of this course, though, is to select. So it says, who will benefit from this course? I want to detect and treat the most predictable and profitable cases. Okay, so we're really focusing on using technology, that app that I just showed you. We're using that technology to help us identify non-extraction cases with adult dentition that are class 1 or mild class 2 or class 3, cases that we can treat with aligners or limited braces or a combination of those. Okay, so we're basically helping you select what I would say is the most profitable, most predictable, I don't say easiest, but most predictable cases to treat in your practice. And that's a great starting spot to get some education, to get some experience, to gain some confidence, to get the system set up in your office to be able to do ortho. And some doctors will choose to stop at that level and say, I'm really enjoying practicing ortho at this level, and this is where I want to stop. Other doctors, though, will want to go on and get more education. Okay, so that's called selective ortho. And let's talk a little bit about what we do in that course in more detail. So in that course, these are some of the things that we talk about. And one is this idea of having an assistant or hygienist scan every one of our patients. There's no cost, there's no radiation, there's no discomfort or waste to the patient. And then while that patient is sitting there looking at a screen with their crowded teeth next to the straight teeth while they're waiting for the doctor to come in, patients kind of self-diagnose. They start looking at the fillings, the things that don't look good to them. They can see it all right up there on the screen, and they might ask my assistant or my hygienist some questions. They might ask about the straight teeth, so that when I come into the operatory, they are already ready to talk about all the conditions that they can see on the scan. So by showing them what I'm seeing in full color up on the screen, I'm able to diagnose all the conditions in their mouth, including the ortho, on every patient, and educate them, help them see what I see and help them know what I know, and then help them make their own decision on how they want to go about treatment. This leads to better dentistry. Okay, you're going to do a lot more and a lot more comprehensive dentistry, the kind that we really enjoy, if we are spending that time to really educate our patients and help them see and understand what we can see and understand. It becomes more education and less sales. It doesn't feel like so much like sales pressure. Not only that, but it documents the starting conditions of the patient mouth and helps us track changes over time. So we can go back and compare what things look like today to what it looked like 6 months or a year or 2 years ago. So after my assistant or hygienist takes the scan, so I would do this on every patient. Obviously, I take x-rays on every patient, but I would also take a full mouth scan on every patient. And it takes about 2 minutes to do a full mouth scan once an assistant or hygienist is well trained. And then it's going to take them about 3 minutes to work that up in the progressive simulation app so that when I walk in, I have these simulations I can start looking at with the patient. Okay. And then I come in and start talking about all these conditions. So I'm using this double occlusal view that I showed you. Here's an adult patient. And I can talk about the condition of the restorations. They usually I'm thinking, oh, that looks fine. And they're thinking like that doesn't look good. I want to fix that. Right. And so they're helping me diagnose and they're helping me decide what's important to them and what they want to change. But by doing this, we're able to be diagnosing and discussing ortho on all of our patients. Prior to this, what I did in my practice was just simply ask every patient, hey, have you ever thought about straightening your teeth? I also had my hygienist at least look in the patient's mouth and say, there's moderate crowding or there's moderate dental class 2 or class 3. So I taught my hygienist to be able to do a basic orthodontic diagnosis so that when I walked into the practice, they could say, there's a broken filling over here. I saw that there's some gingivitis or some inflammation in their gum over here, and they have moderate crowding and mild dental class 2. And then I would look at the patient and go, hey, have you ever thought about straightening your teeth? And that's how we started the conversation. But now with the scan, the hygienist can actually show me on the scan all the things that they were looking at together. And then they've already talked about ortho, it's sitting right there. But diagnosing ortho as part of the oral condition on all of our patients is such a key to increasing the profitability of your practice and the level of care that you're providing to your patients. Remember, it's not just about aesthetics. It's more about function and health. And then if the patient is interested, what they want to know is, well, can I use aligners or brackets? Do I need to have teeth pulled or not? How much is it going to cost and how long is it going to take? And so this app is able to allow me to answer that question right there. So by looking at this app right there with them, I can see whether this is a case where the teeth are advancing way too much and there's going to be too much protrusion. And so there's no way to treat the case except for doing extractions. And if I'm not going to do extractions in my practice, if I'm sticking to the selective cases, the selective ortho, then I'm going to refer that. And how much more is your orthodontist going to love you when you're starting to refer patients out who've already seen their teeth get straight? They already know they probably need extractions. Um, it becomes a qualified referral. But I can tell the patient, yes, I can treat you non-extraction. We'll probably have to expand and maybe make your teeth a little bit smaller in between, but I think we can do it non-extraction. And then I can look at that aligner output, which is slow. And if it says 56, then it probably is going to take me about 56 weeks of treatment. Plus, I would give myself 6 months of wiggle room for patient noncompliance, for revisions and refinements. So I would say you're going to be 12 to 18 months of treatment, or you're going to be 18 to 24 months of treatment. So it gives me all of the information I need to be able to actually close the case. And then if the patient wants to have treatment, we can finish taking the photos that we need to take, which we'll talk about when you come take the education. And we'll be able to start treatment at the next visit. I'll have either brackets to put on or I'll have aligners to deliver at the next visit when the patient comes in. So case selection, especially early on in your career, is key to gaining experience and confidence. So if you learn how to use the software, you're going to learn how to know which cases are good for you to treat non-extraction. And you're going to see which ones have these yellow or red flags that are saying, hey, the bones are out of whack, they're not well aligned, or in the vertical dimension, you're going to struggle because you have some real vertical discrepancies. This patient is in, I'll show you in a second what I mean by that. Okay, but you're going to learn what flags to look for in the software and how to evaluate how much the teeth are advancing in this patient's face. And so you'll easily be able to look at and say, this is a good case for me to treat, or I need more education, or I need more experience before I treat this case, so I'm going to refer this case. And then we do have coaching, consulting, and mentoring services. We'll talk about that more in a little bit, but coaching is free. You know, asking a quick question of a coach, hey, is this a good case for me to take? Is this a good simulation? We have a tool in place in the software that allows you to connect to a coach, which is one of our instructors, who will help you answer quick questions about that case. Like, yeah, this would be a good case for you to treat. That looks like a good simulation for you. And then if you want more help in setting up your aligner case, evaluating the aligner staging and see if they can optimize that for you, helping you along the way, we have other levels of paid services, which is consulting and mentoring. And using a consultant and mentor initially for me is what really helped me be successful, because you don't want to be an imposter, right? And so I'm sitting there with my patients and I want to confidently look at them and say, hey, we're treating orthodontic cases in our practice now. Susie up front is wearing aligners right now. And we're really excited that we're doing ortho in our practice. And you are a good fit for my practice. And so if you'd like to have treatment done, we can do it here. You want to confidently be able to say that, even though you might only have Susie as the only patient who's actually in treatment. And so to be able to confidently look at your patient and say that, to me, that comes from knowing that I have a consultant or mentor that I'm working with who's got my back and who I can ask any questions to, and I can get help from them. And yeah, I'm paying them a fee. Usually the consulting is around $300 a case. The mentoring, which is where we help you all the way to the end of the case, is usually around 600. That fee is set by each individual consultant or mentor. But having that for my first, I don't know, I probably use that on my first 20 cases just routinely. And then as I started going, okay, this case I feel good about, this case I feel good about, that one I think I need some help with, and I became more selective on it. But having that consultant or mentor for me is what made me be able to confidently tell my patients, like, I do this now. And we can do this in our practice for you, because I know I've got somebody to back me up. Okay, so in the course, one of the things that you're going to learn about is how to understand what you're seeing when you look at patients, because prior to learning ortho, these pictures right here didn't really mean that much to me. I didn't really see anything here. And now that I've been doing ortho for a long time, I see in these three images, three patients that are so dramatically different that it would be like having a big boat that I want to pull and not knowing which of those three trucks would be a good option to pull that boat. You guys can all look at those three trucks here and you know exactly what you're looking at. You're looking at how much muscle and how much power and torque and force there is behind each one of these engines, because we're familiar with this. So we know how much muscle there is in each one of these different trucks. And so knowing that, we know what they're capable of, we know how they move, we know how they respond when we step on the gas. Looking at these three different lateral cephs right here, we will learn how to see something is dramatically different between these three people as we see between these three trucks. So here, this is what we call skeletally closed or deep or low angle. What you should see here is somebody who has incredibly strong muscles, incredibly dense bone. You can even see that they're breaking and losing teeth. They've got tons of restorations in their mouth. They're just beating the heck out of their teeth. And you have to know that that's really hard ortho on this patient. Their bones are really dense. Extracting a tooth would be really difficult because their crown would break off and leave the root behind. They have small clinical crowns from under erupted teeth. So aligners aren't going to be a very good choice for this patient. I definitely wouldn't put an Emax bridge on the back of this patient's mouth. But then you go to the other opposite extreme, to the high angle or the open patient, skeletally open patient. And this one's got weak muscles. They've barely worn their teeth at all. They tend to have dental open bite in the front. They have low bone density. These are the patients you could extract a tooth without even using a forceps. You just get an elevator in there and you can take that tooth out. Their teeth move very easily through their bones, and they have very large clinical crowns because the teeth have over erupted because they don't hardly ever bite their teeth together. And then in the middle, you've got your average muscle strength patient with average bone density and average clinical crown height, and their teeth move normally. So between these three patients, I see three very different cases. And even if I'm not doing ortho on this patient, I'm making a decision about how I'm going to restore their mouth. I will make different restorative decisions because I understand what I learned orthodontically. Okay, so we spend a lot of time talking about these kinds of things to help us understand what we're seeing when we look at our patients. So you see the low angle, the average, and the high angle patient. And then that translates into these different face types. We have the brachyfacial. I think of it as the patients who break everything, but they have the strong muscles of mastication, the square, kind of wide face. The lower third of the face is usually shorter than the upper two-thirds of the face. They tend to have wide dental arch forms, and they tend to have a deep bite, deep dental bite, and a concave profile. Your normal muscle strength patients, we call these mesofacial. Okay, they have generally a well-balanced face height to width ratio, and they tend to have average dental bite and straight profiles. And then the dolichofacial patients, they have weak muscles of mastication. They have long, narrow face heights, narrow dental arch forms. Sometimes they're mouth breathers. Sometimes they have tongue thrust. Sometimes they have dental open bite. They're very different patients to treat orthodontically. And not just orthodontically, but they're very different patients to restore. One patient, the skeletal closed one, is the one that when they come in, after you put a crown in, they come back in because the crown keeps hurting because the bite's off just a teeny little bit. And then after 6 months, they've distalized the crown and now there's a big gap opened up and they're catching food. And this patient is the one where you could put the crown in and have a completely high spot. It's the only thing that hits when they bite down and that doesn't even bother them. So very different. So, I these guys can break a zirconia bridge, and these guys you could put an Emax bridge on their posterior teeth and they probably wouldn't break it because they just don't bite that hard. And then that translates into face types. So we look at patients, and every time we go to treat a patient, we're looking first at the face before we look at the teeth. And we go, hey, does this patient have a concave profile or a straight, well-balanced profile, or do they have convexity with protrusion in their lips and protrusion in their teeth? Do we want to leave their lips about where they are in our treatment, or do we want to push them forward, or do we want to bring them back? Okay, so these important decisions and how we're going to treat cases and what types of cases we want to take, this is what we spend time exploring so that you have confidence selecting the best cases for you to treat. You can see that these incisors all have very different inclinations to start. The strong muscle patient, you can see these very retroclined or tipped back teeth. And this average muscle strength patient, you can see average incisors in their inclination. And this weak muscled patient, the skeletal open patient, you can see that there's more proclined incisors because everything tends to drift forward on this patient. Okay, so when you start to understand how this dynamic orofacial complex works and how the muscles work together with the teeth and the bones, it all kind of starts to make sense and you start to see a lot more clinically, even if you're not going to be doing the ortho. I call it looking through orthodontic lenses. Okay, so here is the dental vertical. It's different than the skeletal. I was talking about skeletal vertical of closed, average, and open. But then you have dental vertical. You've got dental closed or deep. You've got dental average, and you've got dental open. And you can have dental open on somebody who has skeletal closed. Maybe they had a thumb habit or a pacifier they sucked for a long time. So on that patient, they're going to be a lot more successful in closing their dental open bite because they have a tendency to want to be more deep. And somebody who's got a skeletal open bite is going to tend to have more of this dental open bite. Okay, so we spend a lot of time exploring these different ideas about the different dimensions that we do treatment in, the vertical, the transverse, the sagittal, okay, and how all of these different things when we do a evaluation, which the software helps us to determine, but all these things are part of us making a treatment decision and it helps us decide whether that's a good patient for us to treat. Okay, so here just a little bit more to explore this. It really isn't the purpose of this seminar, but I just want to give you a taste of some of the things we talk about. A lot of us don't take lateral cephs on our patients, but it's really a standard of care. And so if we're going to treat our patients at or above the level of the specialty, which is what we want to do, then we have to get the basic records. And then, so in addition to photos, getting a lateral ceph is part of doing good ortho because it allows us to see whether the patient is skeletal deep, open, or average, and whether the patient has skeletal class 1, skeletal class 2, or skeletal class 3. So it's not just about how the teeth relate in these different planes, but it's also how the bones relate in these different planes. Because you can't put the teeth where you don't have bones to put them. Okay, so when you have these different relationships of the jaws, of where the bones are, I'll show you this real quick, and we'll go back to that slide. Okay, so where the teeth are would be the blue. So you can see here we've got the teeth well related in all three of these, yet the jaws are only well related in the top. And then here in this one, the jaws are not well related because the upper is more forward than the lower. And then here the lower jaw is more forward than the upper, but yet the teeth are all well related. And then in each of these three different rows, we have a different combination of the teeth relating well or not in the sagittal plane and the bones relating well or not. And the bottom line is that when the bones are in class 1, when they are well related to each other, it's easier to get the teeth to relate well to each other. Okay. And when the bones are not, when they're out of harmony, it's hard to get the teeth into good relationship, into good harmony, into class 1. So looking at this patient who's retrognathic and possibly a candidate for surgery, you can see over here in this little moving animation on the right that when the patient's jaw is moved forward through surgery, the incisors can be at the ideal inclination because the bone is where it needs to be for the tooth to be at that inclination. But if the bone is not well related, then you have to have the teeth compensated. So you can see in this case that the upper incisor has to tip backwards and the lower teeth have to tip forward or procline in order for the teeth to relate well when the bones don't relate well. So that makes for a more difficult orthodontic treatment. And the further away they are from having good harmony in their bones, the harder the case is going to be. Here's a class 3 case with a prognathic mandible, where this patient could benefit from surgery. But if you didn't do surgery, then you'd have to compensate by allowing the teeth to not have ideal inclination. So you can see that when the jaw is brought back surgically, the teeth can have an ideal inclination. But when it's not, then the upper incisors have to be tipped forward or proclined, and the lower teeth have to be tipped back or retroclined. And so this is called dental compensation. So the more of these problems or challenges that you have with your case, the more difficult that case is going to be. So skipping back to this picture, okay, this is how the teeth relate in the sagittal plane. So we can have dental class 1, we can have dental class 2, where the upper teeth are more forward than the lower teeth, or we can have dental class 3, where the lower teeth are more forward than the upper teeth. And so in each individual case, we're diagnosing how the bones relate and how the teeth relate. And then we're making a decision about how difficult or not the case is going to be to treat. Okay, so the further a patient is away from ideal, meaning how far are they away from the ideal relationship of the bones in these three planes of space, in the sagittal, vertical, and transverse or horizontal? And how far away are they in the dental relationship, in the vertical, in the transverse, and in the sagittal? And then do they have symmetry? You know, do the tooth sizes, the size and shapes of the teeth ideal? Are we missing teeth? Do we have bridges? Do we have implants that won't move? Do we have ankylosed teeth? Do we have systemic health? Is there something the patient's doing that's going to make this case difficult to treat because they're not healthy? I wouldn't pull a tooth out on them because they might not heal. Then I might not want to move teeth on them. Okay, so we learn about Dr. Andrew's 6 keys of occlusion. And we have an ideal treatment goal. We would, of course, want to accomplish a class 1 molar relationship and have ideal harmony of the way that the teeth relate to each other. We'd want to have ideal crown angulation and inclination, which is really only going to happen if you have the bones also relating well to each other. We would want to have no rotations, no spaces. We'd want to have a flat occlusal plane. But what's real for each patient oftentimes falls short of what the ideal is because we really can't achieve the ideal on every patient without surgery. There's just things that happen when people are developing or in their genetics or in the way that they function that just does not allow for ideal. So we have to be able to look at a case and say, I can treat this case. I can reach the goals for this patient, even though they might not be ideal, and understand what's appropriate and what's not. So to help us with that, in this app that I showed you, we have this traffic light system to help with case selection. So we have green, easy, yellow, moderate, red, difficult. And the idea with this selective ortho education is to use this technology to help you quickly and easily select the easier to slightly moderate cases to help you get confidence and experience. Okay, so it very quickly gives you this green, yellow, red light traffic system to help you identify the skeletal anterior posterior, so the sagittal, and the skeletal vertical relationship, and the dental anterior posterior. Then we also have to consider the dental vertical, whether they have deep bite or average bite or open bite, and we have to consider how much incisor advancement is happening when we straighten these teeth or retraction. If they have spaces, then we're going to be retracting the teeth to close up the spaces. But if they have crowding, then we're going to be advancing the teeth. So when I showed you that overlay where we looked at the simulation laid over top of a lateral ceph, or when I showed you the superimpose tool where you could see when in purple where the teeth started and where they ended up, those tools help us to quickly and easily see how much incisor advancement we're going to have. So this tool can really help us select the best cases and limit ourselves, if we're new to ortho, to those cases that we're going to be successful on and that are going to be just easier to accomplish and that are going to feel more productive in your practice. And then the moderate to severe dental open bites or deep bites, or ones that have a lot of incisor advancement, those are going to be more difficult cases that we either want to refer or that we want to get more education and more experience so we can treat them. So the selective ortho case selection criteria is we're looking for green or very close to green, like I showed you, where it like just barely crossed over into the yellow. We're looking for the green light in the skeletal anterior posterior. That's in the sagittal. So more like skeletal class 1. We're looking for the green light in the vertical. So they're not real open and they're not real closed. They're that average muscle strength patient. And then we're going to look for the green light on the dental classification. So they're either dental class 1 or they're close to dental class 1. Okay, they're only maybe a millimeter or two away from dental class 1. And we're only going to want mild vertical problems with the dental bite. So we don't want a real severe deep bite where you can't see the lower incisors, or you don't want the one where you have a severe open bite. Just very moderate amount of deep bite or open bite that you might be able to treat with these easier cases. And then with transverse problems, we don't want to take on somebody who's got a full cross bite on one side or a whole arch, a whole quadrant that's in cross bite. Maybe if there's one or two teeth that are out of alignment in cross bite, but not a whole section, like the whole anterior or the whole right side or the whole left side or everything. Those are more complicated cases. So we're limiting ourselves to these non-extraction, adult dentition, dental skeletal class 1 cases with maybe just a little bit of incisor advancement, maybe up to 2 millimeters of incisor advancement. Those are the cases that are going to be really productive and really enjoyable for you to do as you gain confidence in your practice. We're going to avoid cases that have these functional shifts where the patient is shifting their jaw to the right or the left. This is cases where the centric relation and the centric occlusion don't match, where there's a big CR-CO discrepancy. Okay, these are more complicated cases to treat, and you can treat them, and we want you to be able to treat them, but you'll need to be able to take more education, and that's what the comprehensive series is for. Okay, so when we talk about asymmetry, we're talking about patients who have skeletal asymmetry, where their mandible or their maxilla are not symmetrical. You could have a skewed or canted maxilla. You could have a mandible with asymmetric shapes left and right. You could have this functional shift of the mandible. And you can even have dental asymmetry, so if there's maybe a primary molar was lost early, so that the adult molar, this upper first molar right here, maybe that erupted more mesially. And so that blocked out this canine. And so now when you look at the symmetry of the arch, the overall arch form looks good, but the dental symmetry is off. The teeth are not symmetrically positioned inside of this arch. And so if you just straighten this person's teeth, the midline would shift significantly. So unless I do something to actually move the molars asymmetrically, then we're going to end up with a midline that's really off. And so these are the things that we help you to be able to recognize. So if you're trying to limit yourself to just the select cases that are going to be more profitable for you, then you have tools to do that quickly and easily. In my practice, I do everything, or I did everything. They say those who can do and those who can't teach, right? So that's why I'm teaching. But I treat kids. I want to treat the kids that are fun and easy to treat, but I don't want to treat the ones that are screaming before I even get in the operatory. And so I refer out the ones that are not productive for my practice, and I keep the ones that are productive. And I do root canals. If somebody's got a lower second bicuspid with a nice straight root, why would I refer that root canal out? I want to do that one, right? It's profitable. It's predictable. I know how long it's going to take me. But if they've got a multi-root lacerated, all this complicated anatomy to their roots, I don't have time. I don't know how long that case is going to take. It's just not profitable in my practice. So I'm going to send that one to a specialist. And the same thing with an implant. If I flap it and there's all kinds of bone all day, that's easy for me to do. But if I have to do all kinds of augmentation to the ridge, that's not profitable in my practice. And we all have different levels of what's profitable for us in our practices. And some doctors who train with us, they want to do all the ortho. And I totally respect that because, there comes a level where you're just like, I like doing this and I want to do all the ortho cases that come in. And I know that I can do them as good or better than the specialist. And so I think that that's awesome. But then there's other doctors like me where I did treat all the cases because I could. And then I said, okay, I know I can do all these cases, but is it profitable for me? Or do I stress out a lot about them and find that by the time I'm done, I didn't make any money on that case? And so, we may limit ourselves to the things that are going to be profitable and predictable to treat in a general dentist office. And so there's a variety of things that you can choose to do in your practice. But that's the purpose of having these different levels of education, is to help you decide what level fits well for you. If your patient needs to have teeth extracted, you either need to have more education, which is what our 48-day course is for, the comprehensive ortho series, or you refer the case. And there's reasons to extract teeth. If the teeth are just going to simply advance too far when we align them, then we need to extract some teeth. If it's going to create protrusion or dental open bite when we align them, then we're not going to do that to our patient. If they already have protrusion, if they walk in and their teeth and lips are sticking out too far, and we haven't even fixed the crowding yet, they're going to have extractions. If they've already got a dental open bite and they're protruded, or if they've already got periodontal compromised recession, then we may need to extract teeth in order to align them. If they've got large amounts of dental class 2 or class 3, we may need to extract teeth to make the space to move the teeth into to be able to do some of this dental compensation that I showed you. Okay, so there are reasons to extract teeth. And when we understand what those reasons are and we learn about it, then we can make decisions on whether we want to treat the case or refer the case. And when you come to the full comprehensive series, then you learn how to do all the extraction cases plus a lot more. When we extract teeth, when we advance teeth or retract teeth, we change the profile potentially, depending on how thick their lips are and how much advancement or retraction we're getting. But it makes sense that when teeth advance to align the crowding, the lips are also going to advance. And for some patients, that might be good. Like this patient here that's got kind of a concave profile. If she has crowding and her tissue is healthy, then advancing her teeth can actually make her face look better because it fills out her profile and gives her more lip support. But for patients who already have or complaining of too much protrusion, I have this picture swapped here. It should be the other way around. If they have too much protrusion to start, then if they're going to benefit from retracting their teeth, then they're going to have teeth extracted in order to be able to retract their teeth and get a change to their profile. So understanding all this stuff, learning it in detail, being able to make these decisions, and then also knowing that you have coaching, consulting, mentoring is really, really helpful to get you started. Coaching, so in that software I was showing you in in MediLink's software, the progressive orthodontic simulation app, there's a button down here that's coaching. And when you hit that coaching button, it's going to take you over to our SmileStream platform. So you'll have to have a SmileStream account, which is free. But you're going to be able to choose from one of our instructors to coach you and say, yeah, that's a great case for you. You know, if you'd like consulting, you can send it to them and get consulting help. But you always have connection to a coach or somebody to help you. Incidentally, if you do happen to have MediLink and you're interested in this app, MediLink is free, so you can sign up for it, by the way. But you won't find this app in MediLink right now because we're still in beta mode. We're pending FDA approval. So when FDA approval, I think we'll have it fairly shortly here, but when FDA approval comes, then it will be available to everybody. If you are interested in having access to that software, we can get you on our list of invited beta users. Just give Iveta an email and she can get you on our list. It's Iveta at posortho.com. And I'll show you her email towards the end of the presentation. Let's just talk for briefly, because we're going to go into this in a lot of detail in our actual seminars. And I want to keep it to the 2 hours that we promised. But one of the things that we're deciding when we make a decision to treat a patient is, am I going to treat them with aligners or brackets? Like, would one of these be better for this patient, or would either work just as well? Okay, so some of the advantages to aligners are the patient can remove them for eating, brushing, flossing, special events. That's pretty nice. One of the disadvantages, though, is that the patient can remove them. And that can be a real disadvantage because then they don't get their teeth straightened, right? But other advantages to aligners are improved aesthetics and comfort over braces. Certain types of dental movements, like upper molar distalization, can be easier with aligners than with brackets, unless you're using skeletal anchors with your brackets. And aligners can also be better for treating dental open bite, non-extraction, than braces, unless, again, you're using skeletal anchors with braces. Some of the advantages to brackets, though, are it's a fixed appliance. There's no dependence on their compliance. You have much better control of the torque, meaning the inclination of the roots. You have much better control of rotation corrections and root alignment with braces, and you can do extraction cases much better with braces because you have control over all of these things. Braces are much better for deep bite cases. Aligners are much better for open bite cases. An advantage to brackets is that there's less lab costs, less actual hard costs for the doctor who's providing the care. But some of the disadvantages to brackets are the aesthetics and comfort compared to aligners. It can be difficult to clean and floss even for an adult. Brackets and non-extraction open bite cases are not a good fit because brackets tend to open the bite more unless you're using skeletal anchors to intrude the posterior. It can be difficult to distalize the upper molars without skeletal anchors, and brackets take more of the doctor time. If I'm treating aligner cases, I feel like I can treat a lot more aligner cases, especially with dental monitoring, than I can bracket cases, because bracket cases just require more of my time to be in the operatory, looking, deciding what needs to be done, and sometimes doing things myself. Disadvantages to the aligners, like I said, you can remove them. The success depends on patient compliance. And aligners definitely do not have as much control of torque, meaning twisting the tooth for root angulation, or I'm sorry, inclination. It also doesn't do as good job of aligning roots, so the angulation of roots, and treating extraction cases, and it's not great at rotations. You can fix rotations, but it's not as quickly done as it is with brackets. And then if you have small clinical crowns, then the aligners don't work as well because you have to have tooth surface to push on with the aligners. And then deep bite cases really are not good with aligners. So each tool has strengths and weaknesses. And when we understand what we have at our disposal, then we can make a good choice. And there are lots of cases where either would work well for the patient. And then I usually tell the patient, hey, here's the advantages of one, here's the advantages of the other, and here's the disadvantages. And they sometimes surprise me. I'll have an engineer guy who doesn't seem to be all that into his looks, and he'll insist on having aligners because he doesn't want brackets. And I'll have some lady who I think is really into her looks who will say she wants brackets because she doesn't want to have to rely on her having to wear them because she's like, I know myself, I probably won't wear them. So you never know what the patient's going to choose if both are an option. In our courses, we'll talk a lot about the difference. How do these two different appliances work? Um, how are they similar? How are they different? We'll go into the different mechanics, the biomechanics of how they work, um, how the teeth actually move. And we'll talk about the different stages of aligner or bracket treatment, because even if you're going to take the selective ortho course with us, you're still going to learn how to do brackets, but you're going to learn how to treat limited cases with brackets, because there's things that brackets can do that aligners just can't do well. And so learning how to use brackets as one of the tools in your toolbox, if you will, or one of those things that are available for you to know how to use, it's really valuable. Okay, so what we do with brackets and wires is basically a bracket is just a handle that's being bonded to a tooth. And then we're going to attach a wire into that bracket. And the first wire that we use is a round in cross section. It's a round wire of different gauges. Usually we start with an 012 or 014 thickness. And it's made out of nickel titanium. So it's incredibly flexible. It's very easy to flex it. You can wad it up in your hand, and then when you let go, it just springs right back to its original shape. So we can tie this wire into brackets that are all crooked and crowded all over the place because we put the bracket in the ideal position on each tooth. So the brackets are all out of alignment. And we can tie this really soft, flexible wire in and just literally let it go. You could send the patient away for 6 months. It's not the most effective thing to do, but if they went away for 6 months and came back, their teeth would basically be straight as long as the bracket stayed on and the wire was in there, because it just slowly applies this force and wants to go back to being straight. So we do our initial crown alignment. We get rid of all the rotations and we basically align the crowns in, anywhere from 3 to 4 to 5, 6 months, depending on how crowded and rotated they are, with this nickel titanium wire. And then if we're going to continue to treat with brackets, then we can move up into other wires. We'll move into rectangular wires that now begin to engage the bracket slots. It looks like this. So you can see in cross section, when we start having a rectangular wire inside of a slot in the bracket, now you have some control over the twist. There's still a little bit of slop in there or play, but there is a point at which it will engage and actually be able to apply some twist or some torquing to that root so that you can change or maintain a good inclination of the root. Now, brackets is aligners compared to brackets is kind of like trying to take a plastic wrench. Maybe, my kids had little plastic tools, and if I go outside and actually try to do a project on an actual bolt using a plastic wrench, that's actually not going to work very well because the plastic is too flexible. And that's kind of like what happens with aligners in the mouth. There are things that we do. We put little pressure ridges to try to apply some pressure to help us with torquing the incisors, but it just is not as effective using a plastic appliance as it is using a metal appliance. Okay, so there's definitely a difference, and we'll go into that quite a bit in our seminars. But if we're going to treat that with brackets, okay, then we work our way up in different size rectangular wires so that we can engage that. It's kind of like tightening up the wrench, where you can engage your bolt a lot tighter and actually apply some more force. And we get to the point where we have a nice stiff wire in there that can really maintain these teeth. And then we can start doing what we call mechanics, where if we've extracted teeth, we're going to start closing up the extraction spaces. We're going to start fixing the bite in the anterior posterior. That's when you see patients wearing elastics, or you'll see coils in the mouth. This is where we've gotten the teeth straight and now we're fixing the bite. And then once we get the bite straight, then we're going to go into another wire, which is round again, but it's stainless steel. This time it can actually bend and hold a bend, not just bounce back to its original shape. And we start to then finish the case. And some doctors now are actually going and doing all of this first in braces, and then they're doing this last little bit of fine tuning with aligners instead of using brackets. And then obviously every case has retention. So we go into a lot of detail into what is the process for all of these things? How does this all work together? How do I do this in my practice? And then just briefly, the biomechanics of aligners is you have a series of plastic trays that are worn sequentially by the patient. Each aligner is made off of a digital simulation, which every step has the teeth slightly straighter than the previous one. So as the patient puts in each new stage of aligner, the plastic deforms as the patient seats it onto their teeth, and that little bit of deformed plastic is what kind of forces the teeth into a new position. So the teeth move until the aligner material is no longer deformed and the aligner feels passive, and then the patient goes on to the next aligner. But to do this, the aligners require intimate contact with a maximum amount of tooth surface. It's not just by, hey, I have enough enamel here to bond a bracket. It's like I have to have good tooth surface. I have to have proper tooth anatomy. I have to have some undercuts in the crowns in order to be able to get this to work. And then we use things like attachments, auxiliary forces. Okay, we go over these things in great detail in our seminars. So they're different. Brackets and aligners are different. And sometimes we do hybrid treatment. So sometimes I'll start a case with, if we have significant rotations or significant root angulation problems or torque issues or tipped molars or deep bite with deep curve of SPE, I might tell the patient, I know you don't want to have brackets. You know, if they say, I really don't want braces, I go, I know you don't want to have braces for 2 years, but would you consider having brackets on your teeth for the first 4 months? And a lot of times they go, well, if it's only going to be for 4 months, sure. And then we can switch over to aligners, sure. And so I can take a case that would not be a great aligner case and turn it into a good aligner case with 4 or 5 months of treatment with brackets. And then there's cases where the patient compliance fails and the aligners are no longer working. And then I have brackets in my back pocket to be able to go finish the case and get myself out of a case where the aligners just aren't working because the patient's not being compliant or the teeth don't want to move or whatever the reason is. So here's an example of a hybrid case. You can see the severe rotation of these lower canines. That would take a long time with aligners. You probably would never be able to get those perfectly straight with aligners. But you go throw brackets on there for 4 to 6 months and you can straighten that all out. And once those rotations are corrected, now you can close up spaces with aligners. You could also do it with brackets, you know? So if this patient didn't care, I'd frankly rather close those spaces with brackets. I'd be able to maintain the torque of those lower incisors better. Whereas the flexible plastic would kind of allow those to tip back a little bit when I try to close these spaces. Okay. But if the patient's insisting on not wearing brackets for 2 years, I can get those rotations fixed and then go into aligners and finish things that didn't correct in the brackets. Like maybe I didn't put this bracket on straight. And so my bicuspid is still got some rotation that needs to be fixed. Right. But I was able to do a lot of work to get these things aligned first. In fact, those are, I said, these canines, those are bicuspids, aren't they, that are rotated there? The canines are actually here. So those are bicuspid rotations, right? But you know, you go in and now you can finish it up with aligners. So just briefly, we do have an awesome aligner company. We are an education company. We do not produce, we don't manufacture aligners, but we have partnered with a really excellent aligner manufacturing company. In my mind, they are the best out there. They are as good or better than a leading brand. And I've worked with all of them, and I really like this particular manufacturer, everything about them. So we were fortunate to be able to partner with them and put our label Progressive Aligners on it, and even have some control over what we do with our particular brand. Okay, so we've really worked to get this really great aligner product from a great manufacturer, designed for you, the general dentist. And why we really like this company is because they have highly trained designers. They're the best trained in the industry. Their designers don't get to work on cases till they've been training for a year versus the couple weeks to a month that other companies allow the designers to start working on cases. They look at the radiographs, they look at the photos, they look at your instructions, and they really have a deep orthodontic education behind them to help them follow your instructions. Now, you still can't just say, well, I'll just send the case to them and let them diagnose it. We still are the doctors. We still make the diagnosis and decide how we want to treat the case. But their job is to stage and design the case according to our instructions, but we want them to understand what we're telling them, right? Some of the companies I've worked with, it feels like I'm training their designers. And I would want to work with people designers where I feel like, they know what they're doing. It's like, I don't want to work with a lab that I'm teaching them how to build a crown. I want to work with a lab that knows how to build a crown. I still give them instructions on what I want, but they know what they're doing. So, with this company, we get with progressive aligners, we have a dedicated team of designers that apply our preferred protocols, and we just get back some really great setups with less back and forth by the doctor. We've also been able to work out, so the simulation software that I showed you, if I pick a simulation there, these designers don't actually get to see that simulation because their software is not set up to be able to integrate that. But I can tell them which simulation I picked, and if I say I pick simulation 2.3, that tells them what the mechanics are going to be without me having to give more instructions. It tells them I want to treat non-extraction and I want to treat with expansion and with IPR, or I want to use class 2 elastics, or I want to use upper distalization. So whatever the plan is that I chose, I can easily communicate that with these designers who understand this number reference that we can give them from our simulations. And that's really valuable to me. They have great material. I mean, the aligners themselves feel awesome. They're really comfortable for the patient. They're very effective. They look great. Top of the line product. Now they have their own software, right? Because it's a separate entity. So the software I showed you before, that simulation, that's something I'm using chairside with a patient to help them want to do treatment and to help me decide how I'm going to treat the case and if I want to treat the case. But then once I send the case off to progressive aligners, they're going to have their own designers follow our instructions and set up another simulation. Okay, so we have really great software called the Doctor Portal software that then you're going to get back the proposed treatment and you can evaluate that with the software and decide if they followed your instructions, if you like the way it's done, if you want to make any changes. This is where consulting services while you're still learning is really helpful because now you have one of our instructors looking at your setup with you and making appropriate changes, optimizing, idealizing the setup so that you get aligners that are built on a really good setup. And then mentoring, they're there to help you with questions all along the way, with revisions or refinements that you need to do to finish the case, which is very common. Okay. Oh, also you can use STL files from any scanner. So you don't, with Invisalign, you can only use iTero scanner. And so, we really like this partner for our progressive aligners because you can use any scan from any scanner. I really like all their features. In our seminars, we talk about these features. We talk about all the different attachments and how they use them. We talk about torque ridges and rotation ridges and intrusion ridges and bite ramps and button cutouts and all of these different things and how to use them. But it is a feature-rich appliance. And then we've been able to work out tier level pricing for the GP. I was always jealous that my orthodontic friends were, because of the volume they do in their practice, that they were able to get discounts that I was not able to get, and I was paying more for the aligners than they were. Because of that, we've worked out a tier pricing for the GP so that at much more reasonable levels of care. So this is for 6 months case start. You get anywhere from 0 to 3 cases up to 40 plus, and there's different discount levels all along the way. But this is really designed for the GP. If you'd like to see some cases and hear some conversation around progressive aligners, I invite you to go to our YouTube channel. So it's youtube.com, look for the Progressive Ortho channel. And we have some different playlists. One of them is the Progressive Aligners Talk Series, and this is myself, Miles McGann, who's our CEO, and Don McGann, who's our founder. Just sitting around discussing why we like this particular aligner company, the different things about the aligner company, the direction that our company's going. So, I think you would enjoy listening to some of the conversation here. You can find that. These are free on YouTube. And there's also 6 free case study webinars. Each of these webinars is like 3 hours long. And 3 of them were taught by me, and 3 of them were taught by Dr. McGann. And those are also on that same YouTube channel. They're free. And so I invite you, if you'd like to go actually look at some cases and go through individual cases, there's like a mixed dentition in here. There's spacing cases, there's class 3 cases, there's crowded cases, there's a functional shift case. That's really interesting. I think you'll like those. There's a hybrid case in there. that was started with brackets and finished with aligners. So if you're interested in more free education, that's somewhere to go, is go check out our YouTube channel and look for that webinars and case studies playlist. So let's talk for a minute about the comprehensive orthodontic series. This is Dr. Pasqua from San Jose, who said, progressive orthodontics is a great system. It's an extensive program which aims not only to form critical thinkers, but to develop leaders in dentistry, pioneers of a new generation of orthodontic providers. And I totally agree. So she took the full comprehensive orthodontic series, which I did as well. And you can treat 90 to 100% of the patients that walk in your practice. You can take on as much as you want to take on because you're trained to do everything. I did several surgery cases, and the oral surgeon that I worked with was initially cautious, and then after we were done, he said that was one of the best setups I've ever worked with for surgery. And that's not bragging on me, that's actually bragging on the program, because I just followed the steps that I was given. I just did what they told me to do. I was working with a mentor, and I just did what they told me to do, and it went great. And after I did a few of those, I was like, well, that's fun. It's rewarding, but I'm not making any money on those. It's taking way too much of my time, and I don't know if it's smart for me to carry the liability in my practice. So I didn't do more surgery cases. But my point is you learn how to do everything, and you learn how to do it really well at the level of or beyond the specialty, in my opinion. Okay, so in this comprehensive orthodontic series, this is for the doctors who, instead of just doing select number of cases, wants to really treat 90 to 100% of the cases that come into your practice. And maybe you start with selective, and if you like ortho, then you build up to this one, or maybe you start with this one. Anyway, these are fantastic lecturers who teach these. Really awesome education, very comprehensive. So teach you how to treat all kinds of class 1, class 2, class 3 cases, kids ortho, mixed dentition, phase 1, phase 2, growth and development, extraction cases, deep and open bite cases, the asymmetry, the difficult asymmetry cases, how to use TADs and skeletal anchorage, how to fix gingival display, even how to do surgical cases. And there's a free lifetime retake policy on all of our courses. So whenever you pay for a course, you'll always be able to go to another live one for free if it's in your area and you want to travel there. Or you can watch the online recorded versions or see the slides online. So it's always available for you lifetime. I'm not going to go through the whole curriculum, but some of the things that you learn in this comprehensive series is how do you start cases? How do you evaluate cases? How do you get your records and do your consultations, and how to trace cephs? And this is where we learned the SmileStream platform, how to do a full tracing of a lateral ceph, how to do a full treatment plan and come up with, a full consultation from SmileStream. And then how to start your treatment, how to bracket, how to understand the appliance that you're using, how to complete the treatment, the alignment, mechanic, finishing stages, and everything you need to know about making that all work. Then you go into class 3 cases and class 2 cases and growth and impacted cuspid retrieval, mixed dentition cases, growing cases, unconventional extractions, and uh, headgears and all kinds of different appliances, treating asymmetries and by protrusions and bone remodeling. I'm just looking here at what's in front of me. It is comprehensive. There is so much that you learn, and it's a 2-year program. You go every other month for a 4-day weekend, and you do it for 2 years, and it's a big commitment of time. But I'm telling you, it was the best thing that I ever did for my career. And then this last section, you have seminars on skeletal anchorage, on surgery, on TMD, implantology. It puts it all together. Okay, so this is a massively advanced course, and I highly recommend it. So I really want to invite you guys to consider coming and learning with us. It's a really fun environment. It's general dentists teaching general dentists. We have a lot of experience. We have a lot of fun. We want you to do everything. We want you to succeed. We're not there to just teach you how to refer. We're there to teach you how to do as much ortho as you want to do. And we really want you to be able to learn techniques and practices that are going to be predictable in your practice, that are going to be reproducible. We've been doing this for a long time, started in 1984, and have become the world's #1 orthodontic education and mentoring system. We actually do have seminars all around the world. And then we have this high level of support that I told you was so important to me, having mentors and consultants. We want you to confidently be able to provide these services in your practice and then earn money while you're learning, take advantage of the lifetime free retake policy. And then this software I've been showing you, this progressive ortho simulation app, this is free. You just need to have a scanner and you need to have a computer that can run it. And SmileStream is an online platform that's free. And we teach you how to use these really powerful softwares to be able to do this in your practice. So to summarize, almost every patient in your practice can benefit from orthodontic care. The majority of orthodontic cases in our practices go undiagnosed and untreated just because we don't know what we're looking at. And unlike most dentistry, patients don't really want what we have to offer unless they're in pain. And even then, they don't want it, but they want to be out of pain. But orthodontic treatment is something that they actually want. It's something that patients have been wanting to do. I mean, I remember this lady who was 80 years old and she's like, can I still straighten my teeth? She's like, I've wanted straight teeth my whole life. And I finally am in position financially to do it. And I'm like, absolutely, let's straighten your teeth. Patients actually want this treatment. The orthodontic cases regularly lead to cosmetic treatment, to implants, to restorative care, to comprehensive dentistry, lots of other procedures. It's just a great thing to do in your practice. When you invest in ortho education and your patients invest in orthodontic care, they're investing in their smile and their health. And because of that, they're more willing to take on other procedures to maintain and improve their smile and their health. And then I also found this for sure. Ortho patients are out there talking about it because it's going on. It's not just something they showed up for one day and it happened and they walked out. And when the numbness wears away, they forget about it. They're in treatment for, 12 months, 18 months, sometimes 2 years. And it's exciting and they're changing and people are noticing. And so they have something to talk about. And it ends up being a leading source of referrals is your patients that are doing ortho with you and really enhances and builds your practice. So I want to open it up for questions in the last like 10 minutes that we have. Iveta is here. She can also answer questions, but I just want to highlight these courses that we have coming up and point out that any first day is free. So if you would like to come try out any one of these courses, you can come to the first day of any one of these seminars. If you see a date or a location that works for you, you can come to the first day for free. Okay, just come sit in, be with the doctors that are deciding to do this, listen to the instructors, get a feel for how the courses go and the content. And if you love it, then you can keep coming or you can find other dates that work for you. But that's kind of our intro for the rest of the year, since our main intro courses are done for the year, is that you can come to any one of these courses one day free. But if you know you want to do this, and I hope you do, hopefully you can find a date or time in a location that works for you to get started with one of these new classes and get started with a new group that's going through. So the Selective Ortho course, we just started one in Orange County, so that one's already underway, but here's the other courses that have not started yet this year that will be starting. And then our comprehensive orthodontic course, here are the locations and dates for new classes that are starting. I'll point out that 3 of these are hybrid, meaning that rather than going to all of the live seminars, these are based upon doing a lot of this on your own with a internet assisted training where you're going to be doing it, as a hybrid, but you're still with a class and you still have to keep up with the class. And then you do come to some of the live sessions where it's most important. So that's a hybrid option for the comprehensive ortho. And then for those who have been through one of our courses, if you've been through one of our previous aligner courses or you've been through our comprehensive course, this new 2-day progressive aligner seminar would be great for you. It's designed for somebody who already knows ortho because it's skipping all of the basic orthodontic principles, all the basic orthodontic education, and just really drilling down on what are the protocols and features of progressive aligners. What are the best tips and tricks and practices for the progressive aligner product? And that's a 2-day course where we still have several of those coming up this year. I'm teaching the Orange County one in July. And then there are other courses not listed here. We have some workshops, some hands-on workshops with this new progressive app to come and learn how to use the app. We have some finishing courses going on, some bracket finishing courses. We have some kid ortho courses going on. We have some courses to train dental assistants. So Iveta or Morgan, I have their numbers and emails listed here. They could answer any questions for you on any one of those things. I thank you guys and would love to open it up for questions. If you have any questions you'd like to ask, you can unmute yourself, or I'm going to look at the chat now. You're welcome to type into the chat any questions. Man, I explained everything. You guys know everything now. There's no
Yeah, that's
questions. This is
good.
amazing.